Let's talk about cancer of the vulva 2021 update. Uh, Vulval cancer is an uncommon gynecological malignancy primarily affecting postmenopausal women. There is no specific screening, and the most effective strategies to reduce vulval cancer incidence is the opportunity to treatment, predisposing and neoplastic lesion as the development. While vulval cancer may asymptomatic, most women present with vulval pruritus or pain or have noticed a lump or ulcer. Therefore, any suspicious vulvar lesion should be biopsied to exclude invasion. Once established, the most common subtype is squamous cell carcinoma. Treatment of vulval cancer is depends primarily. The treatment of the vulval cancer primarily depends on the histology and surgical staging. Treatment is predominantly surgical, particularly for squamous cell carcinoma, although concurrent chemoradiation is an effective alternative. Particularly for advanced tumor, you should go for chemoradiation therapy. Management should be individualized and carried out a multidisciplinary team in the cancer center explaining the treatment of this tumor. The introduction vulval cancer is an uncommon, accounting only for 4% of gynecological malignancy. Squamous cell carcinoma of the vulva is the most common subtype, has traditionally been regarded as a disease of postmenopausal women, although the mean age of incidence has fallen in recent years owing to the increased HPV infection worldwide, reinforcing the epidemiological changes. Difference in terms of current incidence or age at presentation can be found between country and region. By different local HPV prevalence, other risk factor, ethnic distribution, smoking, atrophy, inflammation, and prevalence of HIV infection. Then epidemic study included the 13 high-income countries noted a significant 40% overall increase in the incidence of vulval cancer. The increase was not evenly distributed across subgroup, across age group, but in women younger than 60 years, overall incidence has increased 38%, whereas no significant increase in the women older than 60 years of age. The anatomy of the vulva, external genital comprises the vulva and the mons phoebis in the pubic area. The vulva is in the anterior triangle of the perineum. The element that make the vulva is include labia majora, labia minora, clitoris, vulva of the vestibules, and urethra and paraurethral glands, skin glands, and greater and lesser greater vestibular gland. The most malignancy associated with the skin of the labia majora, malignancy arising from the clitoris and vestibular gland is extremely rare. Lymphatic drainage from the vulva is primarily by to the inguine of humoral region, secondary to the external and internal accretion. This drainage is shared with inferior third of the vagina, the most external portion of the anus below the sinus sphincters. Depending on the localization of the primary tumor, its size, its closeness to the midline, the lymphatic drainage can be unilateral. If it is close to the midline, the lymphatic drainage can be unilateral bilaterally. If it is closer or to completely to the midline, complete or to the clitoris, the drainage can be directly. It can goes to the iliac region. Prevention, how we will prevent the cancers: primary prevention, secondary prevention, tertiary prevention. The primary prevention is by vaccination. As cervical premalignant lesion predisposing to cervical cancer, persistent HPV infection, particularly HPV 16 subtype, has been associated with long-term development of high-grade squamous intraepithelial lesion and squamous cell carcinoma of the vulva. The vaccine is efficacy is more than 90%. The long-term trends analyze the promising estimate reduction of HPV associated cases of vulval cancer in future year among HPV vaccinated community. Secondary prevention, there is no evidence of specific screening for vulval cancer. Self-examination with lichen sclerosis condition related to the vulval cancer development should be encouraged. In addition, there should be early evaluation of any patient with symptoms including vulval pruritus, signs of pigmental lesion or irregular ulcer who make a candidate for skin biopsy. Finally, women who are known to have a squamous intraepithelial lesion of the cervix and vagina or anus should have also inspected of the vulva as a part of their follow-up colposcopy visit. Then tertiary prevention, management of premalignant lesion, and an effective strategy to reduce the vulval cancer incidence is the opportunity to treatment of already if there is any predisposing or pre-neoplastic lesion associated with vulval cancer development, you should go for to treat that pre-cancer lesion to prevent the vulval carcinoma. There is two main pathological pathways that lead to vulval cancer. One is keratinase squamous carcinoma, another one is the basaloid or basaloid or Wati type of squamous cell carcinoma. The cutaneous squamous cell carcinoma usually it is found in the older women and is usually associated with lichen sclerosis and are differentiated in vulval intraepithelial neoplasia. Then what your basalite squamous cell carcinoma generally occur younger women. It caused by persistent infection with oncogenic strain of HPV 16, 18, 38, 33, the 18, 31, 33. The squamous intraepithelial lesion is as a precursor lesion. The lesion are frequently multifocal, may be associated with this squamous intraepithelial lesion in other part of the lower genital tract like cervix, vagina, anus. HIV infection, cigarette smoking also associated with predisposing factor. The terminology, definition, pre-malignant, precursor lesion, vulvar cancer have been reviewed, changed at the last year. Currently, such lesions arising from the vulva and the anus are all included as a name as lower anogenital squamous intraepithelial lesion. Under this classification, there are three subtypes are distinguished of the vulva as is low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion of the vulva, and differentiated variant three types. Okay. There is up to date there is no definitive treatment. For conditions such as lichen sclerosis. A cornerstone measure including avoiding exposure to precipitative factor, trauma, local irritant, occlusive, moist environment. Alternative options include those of topical calcineurin inhibitor, tacrolimus, retinoid, photodynamic therapy. For selected cases, case resistant to corticosteroid therapy, you should give them surgical treatment when scarring or functional treatment. New recent advances like mesenchymal stem cell or adipose derived stem cells, autologous platelet PRP treatment, platelet-rich plasma in treatment of lichen sclerosis can be used. Then this is the vulvar intraepithelial neoplasia terminology. One is vulvar intraepithelial neoplasia 1, that is low-grade squamous intraepithelial lesion. Here low-grade squamous flat condylomata or HPV effect is LSIL. This is VIN2 or VIN3 is VIN is usual type, that is VIN Wati types or VIN bacillus type or VIN mixed is under an HI cell group. Differentiated VIN is VIN and differentiated VIN DVIN. There is progress to squamous cell carcinoma, it is 33% in DVIN and it is less than 5% in VIN1 and VIN2, 3. DVIN usually present less than 5% pre-neoplasia lesion of the vulva. However, it is characterized by higher rate of progression, that is 33% to squamous cell vulval carcinoma, shorter time interval to progression, higher recurrence rate than HSIL. So it is rarely associated with persistent HPV infection, less than 2%. The excision with 0.5 to 1 cm margin constitutes the treatment of choice. Allow for evaluation next to occurred immunization. Multiple treatment modality exists in the management of HSIL, but simple excision with 5 mm margin, 4 mm depth is the most common treatment for HSIL. Excision has the advantage of excluding invasion histologically, but the lack of preservation of vulvar skin resolution, psychosocial morbidity, particularly in women. An alternative option to preserve anatomy of the is ablation, carbon dioxide laser, but with the lack assessment of occult immersion. Use of immunochemo 5% avoids carrying of sexual dysfunction, particularly multifocal lesion. 6 month temporary surgical management, laser epilepsy. The management of vulval cancer and at the primary site malignant tumor of the vulva should histologically confirmed and classified when the primary site of origin is tumor is vulva. These include the tumor that involve both vulva and vagina, but exclude secondary tumor and genital external genitalia. Lymph node, inguinal and femoral lymph node, the first site of spread, followed by the pelvic node. Depending on the tumor size, location closer to the midline or to the clitoris, the risk of nodal lymph can be unilateral or bilateral. Women who have a pelvic lymph node metastasis or extra pelvic metastasis is considered as stage 4 disease. Pelvic ho gaya. If there will be pelvic lymph node metastasis or extra pelvic lymph node metastasis spread, that will be considered as stage 4 surgical staging. Vulval cancer has surgical stage, Figo staging. You see this Figo staging. The new staging is applicable most of the malignancy arising from the vulva except the melanoma. The histopathological types, squamous cell carcinoma account for most vulvar cancer, more than 80% as SCC. Melanoma are the next most common cancer. Rare histological type like basal cell carcinoma, verrucous cell carcinoma, adenocarcinoma related to extramammary Paget disease, vulval Paget disease, and this Bartholomew gland carcinoma, squamous adenocarcinoma, transitional cell carcinoma, or sarcoma. This is the staging of vulval 2022 update staging. Stage 1 is tumor is confined to the vulva. 1A, 1B. 1A is tumor size is less than equal to 2 cm and stromal invasion is less than equal to 1 mm. This is called microinvasive cancer. 1B is tumor size is more than 2 cm, stromal invasion is more than 1 mm. Then stage 2, tumor of any size with extent to lower one third of the urethra, lower one third of vagina, lower one third of the anus with negative node. In 1 and 2 both are negative node. This stage 1 is 1A, 1B is equal to early vulval cancer. Rest is 2, 3, 4 is advanced vulval cancer. Then stage 3, tumor of any size with extends to upper part of adjacent perineal structures with or without any number of non-fixed non-ulcerated lymph node. 3A is tumor of any size with ridges extend to upper 2/3 of the urethra, upper 2/3 of vagina, upper bladder mucosa, rectal mucosa, or regional lymph node metastasis less than equal to 5 mm. 3B, regional lymph node metastasis more than 5 mm. Regional lymph node metastasis, 3C regional metastasis with extra capsular spread. This point is extra capsular spread. If you got extra capsular spread, it will be included in the stage 3C. Okay. Then tumor of any size, stage 4, tumor of any size fixed to bone or fixed ulcerated lymph node metastasis or distance metastasis. 4A, 4B. This is fixed to bony pelvic bone or fixed to ulcerated lymph node metastasis, distance metastasis. 4B. Depth of invasion, always depth of invasion is measured. Depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic tumor arteries to the deepest point of invasion. Regional lymph node including inguinal femoral node. Then histological type, grade 1, grade 2, grade 3, well differentiated, moderate, poorly differentiated. Treatment, the treatment of vulval cancer depend on the primary and the histology and staging. Other variable influencing age and existence comorbidity, performance status of the patient. Treatment is primarily surgical, particularly for squamous cell carcinoma, although concurrent chemoradiation is an effective alternative. Particularly for advanced stage cancer, we go for chemoradiation. For exenteration, it will be necessary to achieve adequate surgical management should be individualized, carried by multi-stream. Other therapy, chemotherapy, immunotherapy, reserved for metastatic and palliative treatment. Psychosocial counseling should be done for pre-invasive vulval disease diagnosis. Management of squamous cell carcinoma presenting symptom, vulval cancer may be asymptomatic. Most women present the vulval pruritus, pain, have unnoticed lump also, then also abdominal bleeding, discharge. Many will have history of vulval symptoms due to underlying lichen sclerosis or high-grade squamous intraepithelial lesion. The advanced vulvar may present with lump in the groin due to the lymph node metastasis. The diagnosis, any suspicious vulval lesion should be biopsy to exclude invasion. This can be done under local anesthetic. 3 to 4 mm case biopsy instrument. Case biopsy instrument has to be used with an incisional wedge biopsy. Even if there is small, it is better not to excite the entire lesion at the time of biopsy, as this makes subsequent definite surgery difficult to plan. If a diameter of the lesion is 2 cm or less, the depth of the stromal invasion is less than equal to 1 mm. On the initial biopsy, it is usual to do radical void localization of the lesion to assess the maximum depth of invasion. If no part of the lesion has a depth of invasion greater than 1 mm, this excision is adequate definitive treatment. Investigation, cervical cytology, colposcopy. Cervical cytology, colposcopy of the cervix, vagina, applicable if due to the association HPV related cancer, other squamous intraepithelial lesion, full blood count, biochemical profile, lipid profile, HIV testing, chest X-ray, CT or MRI scan of the pelvis, groin may be helpful, especially for locally advanced tumor for detect any enlarged lymph nodes in the groins or pelvis, erosion to the underlying bone fixicity, other metastasis. In addition to CT or MRI could be useful for the treatment planning. 18 FDG is positive. PET CT scan is more effective assess the and detect the inguinal lymph node involvement compared to CTs. PET CT is more important than CT. Influence the planning on primary surgery and inguinal lymph node dissection. Inguinal lymph node dissection to the optimal surgical extent without any sentinel lymph node dissection or usual dissection. Additionally, PET CT might be used with larger tumor with metastatic disease suspected in the recurrence scenario, particularly when concentration is continued. Surgical management of vulvar carcinoma should individually the most conservative operation that will we should go for now. They are not going for radical vulvectomy. They are radical wide local excision was a conservative approach. That is a cure of the disease and the should be performed. More importantly, the treatment option consider the most appropriate treatment. The primary is the lesion, the growing lymph node. They have to do them separately. You have to remove the lesion and the lymph node. You have to give incision, remove the lesion. Give here one another incision, remove the lymph node separately. Here they have written the primary lesion has to be excised separately, and the growing lymph is from a different incision. We have to remove the growing lymph node should be considered independently of each other to maximize the chance of cure while minimize the treatment related morbidity. The microinvasive vulvar cancer stage 1A. Stage 1A, how will treat stage 1A vulvar cancer defined as the lesion measuring 2 cm or less in diameter with a depth of invasion is less than 1 mm or less. Depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic tumor free later reach to the deepest point of invasion. The lesion should be managed radical wide local excision without not necessary of growing lymph node dissection, as there is chances of lymph node metastasis 0 to less than 1%. Early vulval cancer, as those confined to the vulva, there is 1A, 1B, where there is no any suspicious lymph node, either clinical examination or ultrasound or cross-sectional radiological assessment. The gold standard treatment for early vulval cancer is radical wide local excision of the tumor. There is effective as radical vulvectomy. Associated pre-invasive disease would be assessed, prevent new tumor arise colorectal. While surgeons would aim for surgical margin at least 2 cm, achieve pathological margin of at least 1 mm. If you are giving a tumor, this is the tumor, you have to give 2 cm margin, 2 cm margin, and during transporting to the pathologist, their tumor size will shrink. There should be at least the surrounding skin, the surrounding tissue will shrink. So at least there will be 8 after fixation. There will be 8 mm tumor free margin should be there for the pathologist to get a complete staging. It is now recognized that the recurrent vulvar cancer probably new. No, the recurrent vulvar cancer is usually a new site that you have developed in the surrounding abnormal tissue rather than the recurrence due to inadequate margin. The deep margin of the excision should be in the inferior face of the urogenital diaphragm. If necessary for distal ones and urethra can be removed to achieve adequate margin without compromising urinary incontinence. Reconstructive surgery, the most commonly utilized flap will be VY flap, rhomboid flap, and gluteus maximus myocutaneous flap. The appropriate management of the growing lymph node is the most important factor in reducing mortality for early vulvar cancer. Is recurrence in the growing region associated poor survival despite using multimodal therapy. Rescue treatment, the current standard involves the resection of the primary tumor and lymph node as through separate incision. This approach allows better healing compared with the en bloc resection of vulva and brain. Inguinal associated higher incidence growing difference with some evidence review suggests that radiation alone can control microscopic small randomized. All women who have stage 1B resectable stage 2 cancer have a should have an inguinofemoral lymphadenectomy. Less than 1% patient who have a small lateral lesion less than 4 cm and more than 2 cm in the vulvar midline. Negative ipsilateral lymph node metastasis in the contralateral growing node. Therefore, an ipsilateral growing dissection is adequate treatment for this patient. If the ipsilateral lymph node is negative, then you go for ipsilateral growing dissection. Patients who have tumor closer to the less than 2 cm crossing the midline, so those having underlevel minor, those who have very large lateral tumor more than 4 cm size, positive ipsilateral lymph nodes, bilateral, you go for a bilateral lymph node dissection. Since the finding Groin's type study European observational center and the role of central lymph node is being central lymph node is utilized increasingly the management of early vulvar cancer in the aim of the procedure to detect the nodal metastasis in the sentinel lymph node which primarily drain the tumor, then to omit or do a full lymphadenectomy sentinel lymph node negative patient, thereby decreasing the morbidity as well as the complete inguinal dissection. The indication for sentinel lymphadenectomy procedure: unifocal tumor size is less than 4 cm, stromal invasion more than 1 mm, tumor size less than 4, stromal invasion more than mm, clinically radiologically negative inguinal femoral lymph node. Sentinel lymph node identified with both radiolabeled and technetium blue dye. Recently, ICG indocyanine grain is used with near-infrared fluorescent technology has become an option to sentinel lymph node dissection. The Groin 5 study already saw Of note, when an ipsilateral lymph node is not detected, complete ipsilateral inguinal lymph node must be done. If an ipsilateral sentinel lymph node is positive, then you go for completely bilateral inguinal lymph node recommended. Grossly positive improved outcome. Several study. Therefore, several studies have demonstrated the prognostic importance of the number of size growing metastases as well as the presence of extracapsular spread. Patients with once more they with pelvic groin radiation positive. Where you go for pelvic groin radiation if these two conditions, if there will be presence of extracapsular spread, that is extracapsular spread is stage 3C and 2 or more positive node. 2 or more positive node, you go for a pelvic groin radiation therapy. All patients who have positive sentinel lymph node, one or more positive beside undergoing full immunotherapy lymphodesiccation should receive radiotherapy to the groin and pelvis. If negative, one or more. Two or more less diameter. In case in terms of radiotherapy, radiation filled external beam radiotherapy should be included the immunofemoral external internal therapy in most patients. Sometimes brachytherapy can be added to anatomical and primary tumor. There are several. Combined photon electron can be used to treat the intensity modulator therapy also you can use. After groin lymphadenectomy, where microscopic inguinal metastasis is found, 50 gray 1.2 to 2 gray fraction usually sufficient. In the case of multiple positive nodal or extra more than 2 node or extracapsular spread, radiation dose up to 60 gray can be given up to reduce volume. Gross residual region will go increase to 670. Initially 50 gray and 2 gray fractions. In multiple positive node or extracapsular spread, 60 gray the recurrence. Gross residual disease usually requires 60 to 70 gray. Advanced vulvar cancer include the tumor that beyond the vulva and where the bulky positive groin. Management of women with advanced vulvar cancer complex should be individually carried out multidisciplinary. When confronted with the advanced vulvar, daily find patient with clinically suspicious node should be have FNAC or biopsy of the node. Pelvic CT, MRI, PET CT can help with the extent of the inguinal pelvic lymphadenopathy, presence of distance metastatic disease. If there is no suspicious either clinically or imaging, no suspicious node detected, bilateral immunofemoral lymphadenectomy may be performed. If the nodes are negative, radiotherapy to the groin will be not necessary. However, if the node is positive, then adjuvant radiotherapy, chemoradiotherapy, groin and pelvis should be offered early stages. In case where surgery is thought to be inappropriate for the individual patient, primary chemoradiation may be used to treat the primary tumor as well as the groin pelvic lymph node. In patients who have clinically positive node, enlarged groin and pelvic node should be removed if possible, and the patient given post-operative groin pelvic radiation. Full lymphadenectomy should not be performed because the full groin dissection followed by groin radiation may result in severe lymphedema. Ulcerated fixed groin node should be biopsied from the to confirm the diagnosis, then treated primary radiotherapy without chemosensitization. If there is an incomplete response to radiation, the node may be then resected if appropriate. An alternative strategy is the use of neoadjuvant chemotherapy with cisplatin or carboplatin or paclitaxel to shrink the node prior to the radiotherapy. In terms of management of primary tumor, the surgical excision of the primary with the clear surgical margin without sphincter damage wherever possible constitutes the optimum way to treat advanced cancer, as well as palliative symptoms, local pain, offensive discharge. If adequate excision of the primary can only be achieved with the excision or the formation of bowel stoma, urinary stoma, radiotherapy should be radiotherapy plus or minus concurrent chemotherapy may be a preferred treatment. If there is your thinking there will be need of bowel or urinary stoma excision procedure, in that case you can go for concurrent chemoradiotherapy. Survival improve post radiation. Concurrent chemoradiotherapy will describe treatment alternative to patient with large tumor with primary surgical resection of damaged central structure like anus tract, urethral compression and long-term compression has been reported. The groin nodes pelvis may need to include the radiation field depending on the status of the groin and determine incident. Neoadjuvant treatment should be cisplatin and 5-fluorouracil. Other chemotherapy has been reported. Effective for preservation of the sphincter urethra and sphincter anal sphincter urethra in patient with advanced vulvar cancer. In relation to the radiotherapy planning, advanced bowling, the growing nodes are positive with previously described indication of adjuvant radiation therapy. Radiation treatment will include the pelvis, inguinal and libra vulva. They should be treated with total dose of at least 50 gray. The attention to adequate coverage the inguinal vulva. Large tumor liquor 16 to 70. Targeted therapy, the targeted therapy, molecular therapy, bulbar squamous cell carcinoma, some study focusing on aberrant cell cycle activity, while other looking at the extracellular growth, regulatory cellular activity such as epidermal growth factor, inhibitor of angiogenesis, possible target HPV associated cancer E667 oncogene with therapeutic vaccine as well as immunobased therapy, while mutant non-HPV associated cancer like P13K, CDKN2A, P10 may be effective target for treatment. Inhibition of EHGP epidermal growth factor has utilized successfully. Published vulvar cancer in phase 2 study, erlotinib EGPR inhibitor has been going on. Closer surgical margin, most vulvar cancer recurrence occur on the vulva. It is thought to surgeons should aim for tumor-free pathological margin 8 mm or more to minimize the local disease recurrence. Two type of local recurrence, those are the same site as the original primary tumor, those are at different site because we are discussing. Recurrence at a remote site later with a median disease are commonly associated with lichen sclerosis. If the patient already has lichen sclerosis, the recurrence is on a different site. As most vulvar squamous cell in the background of atypical schemes such as HSI lichen sclerosis, different BIN, as they characteristically recur locally but often at a site remote from the original tumor. It suggests that many recurrences may actually second primary tumor which arises in a field of cancerization area of genetically altered perineoplastic epithelium. Patient with close less than 5 mm surgical margin may benefit from post-operative radiotherapy. It is not possible to re-excise the margin. Patient with close less than 5 mm surgical margin may benefit post-operative therapy. Occasionally positive margin was provided therapy. Recurrent disease, the management recurrent disease of difficult treatment option depend on the site of the recurrence, the performance surface. Includes the surgery or chemo radiation, neoadjuvant palliative chemotherapy, targeted therapy. The patient has to be followed. Local recurrence most often occur in the first 2 years of the disease treatment. Most aneurysm malignancies in every 3 to 6 months first year, maybe 6 to 12 months, then next 5 until their 5-year post treatment. Elevated free treatments, serum concentrated squamous cell carcinoma antigen may be independent from risk factor for disease-free survivor used as a serum marker for surveillance. Squamous cell carcinoma antigen used for serum tumor marker for surveillance. Rare vulvar malignancy, bulbar melanoma, second mass malignancy, mucosal melanoma on the vulva and in the vagina. Any pigmented lesion has to go for oxygen exercise and do a biopsy to confirm the diagnosis. Most location clitoris and labia minora. Their lack of consistency. They should the HSCC classification system or the Breslow classification system has to be used for staging. Figo staging system not to be used. Surgery the treatment choice. Vulvar lesions should be treated radically wide location. Margins at least 1 centimeter. They found in patients that undergo local extension of the radical. Role of lymph node resection is controversial. To date, no survival advantages in lymphadenectomy. 60-year or younger patient with tumor 1 to 2 mm, patient with no tumor ulceration, it will have to remove lymph nodes clinically imaging. Sentinel lymph node has been explored for melanoma, that is false negative rate more than 5 times, suggests that not currently the standard of care. Sentinel lymph node melanoma. Bartholin gland cancer with the vulvar malignancy 5% account for 5%. Squamous cell variant, either transitional cells as well the docked adenocarcinoma of the gland, adenocystic or adenosquamous variant. Intense PP60 expression consists of the presence of HPV vaccine, HPV. The diagnosis is often made after resection with the persistent recurrent Bartholin cyst. Bartholin gland carcinoma effectively treated with a radical vulva. This here only you can go for radical vulvectomy in Bartholin carcinoma and bilateral groin dissection. The location is rectal fossa. Paget's disease of vulva, extra mammary Paget disease rare. It can affect the apocrine gland of the vulva. Apocrine. Two types, primary form being intraepithelial lesion, but the secondary is due to the invasion from the underlying adenocarcinoma, which may be from the surrounding adenocarcinoma of the surrounding structure like anorectal, urothelial, genital tract carcinoma, endocervical or endometrial. Vulvar Paget disease predominantly post-menopausal. Vulval pruritus, pain on examination, eczematous sweeping lesion on the skin. Diagnosis is usually confirmed by the biopsy, has to differentiate from the intraepithelial investigation. Treatment of choice is intraepithelial white local excision. If underlying adenocarcinoma is present, treatment should be radical white local excision with margin of at least 1 centimeter. With inguinal should be performed with the adjuvant radiation of the same indication of squamous cell carcinoma.